don't do very well with non-invasive CPAP. So, non-invasive ventilation is taking the whole non-invasive respiratory support forward in order to prevent invasive intubation, endotracheal intubation, and keep babies off the invasive risks of nosocomial infections, volar trauma, and everything. Before I start this talk, I'd like to disclose that I did receive a travel grant from Stefan Medical Company, who is also producing some ventilators for non-invasive ventilation. Now, we heard a lot about physiological effects of CPAP, the potential benefits. I'm not going to go there any further, but I'd like to share with you some data of a group that looked actually into the effect of ventilation on brain. So unfortunately, Jerry is not here anymore because he was saying it's all about ventilation here. I'm going to take the afternoon off to see Cracow. But actually, this is a study that was done in baboons, where recent co-workers looked into the effect of merely ventilating a neonatal baboon or taking it off the ventilator. So these were rather healthy baboons. They were either extubated to nasal CPAP after 24 hours, or they were continuously ventilated, but only after 5 days. And then they looked just into the anatomical changes of the cerebellum. And as you can see here, the cerebellum of an only 24-hour ventilated baboon was quite similar to those that were ventilated briefly, and was much more affected just by ventilation if this ventilation was continued for a couple of days. So it's not only about ventilation, it's also about protecting the brain. So the physiological effects of CPAP have been discussed, but there are also harms, and we heard about that. And the question is, can we do any better? And one of the side effects you've seen is something like that. You probably have seen that in your unit. That's the accumulation of air in the gut during CPAP. Now, when we go back to the CPAP systems we are using, there are basically, it's all more or less the same. We have a device that generates flow. If it's a ventilator, it's going to be continuous flow or demand flow, or we have a flow source with a continuous flow from the wall going into a bubble CPAP. We have MediJet or others, and we have infant flow. And we can measure pressure at the airway opening, and pressure is actually controlled by an expiratory valve. That could be a surgical chamber with water, like in the bubble CPAP, or the valve in the ventilators, or the devices that are used. And the other thing we just saw also is the interface. You've seen Peter's slides with Hudson prongs. There are other prongs. You can use an endotracheal tube just put into the nose, or other nasal prongs, nasal cannulas. Now, we heard already about CPAP failure, and in the very small infants, in a lot of studies, there were up to 50% infants, or even more in the support trial, that failed CPAP as an initial treatment in the delivery room. There's one study with bilevel CPAP that actually was done here in Poland, so that's why I cited, where bilevel CPAP was shown to have less CPAP failure as compared to only nasal CPAP here. And there are several other studies. So the question is there something in between invasive mechanical ventilation and nasal CPAP? You would have the high-flow nasal cannula on the right. This is in Italy, in the Chianti hills of Italy. And there is a small cloud in here, which might be non-invasive ventilation. We're going to talk about that. So non-invasive ventilation is now an additional mode of non-invasive respiratory support where we have a ventilator attached to the tubing system that non-invasively provides time-cycle pressure-limited mechanical ventilations. And the rest is pretty much the same. Your devices can be the same. And your regulatory pressure devices might be also the same. Now, if we talk about non-invasive mechanical ventilation, the problem is that naming is not very consistent throughout the literature. We barely know what we are talking about. If we talk about non-invasive nasal intermittent mandatory ventilation, some authors would use the same naming for synchronized non-invasive nasal mechanical ventilation or synchronized non-invasive positive pressure ventilation. And just recently, a new mode of non-invasive ventilation came up called nasal high-frequency oscillation. So just to begin with, the nasal high-frequency oscillation is a form of non-invasive support where basically a high-frequency oscillating device, a ventilator that provides high-frequency oscillation, is applied to the nasal cannula in order to ventilate or to support this baby. And there are no clinical trials so far other than bench studies like this one from Marcacci and co-workers, and some Italian colleagues have started to investigate that. And these data here illustrate the effect of nasal high-frequency oscillation on the elimination of CO2 as compared to merely non-invasive positive pressure ventilation or CPAP. But this is a bench study where an artificial lung was used that was filled with CO2, and they actually just measured how much CO2 they could eliminate from this mannequin. And as you can see, the CO2 elimination in the nasal high-frequency oscillation was significantly higher as compared to nasal CPAP and N-IPPV, depending on the frequency they apply. And there is kind of a peak of frequency, which is quite comparable to what we are using in invasive high-frequency oscillation at around 10 Hertz. So it will be interesting to follow up on these studies in order to see whether high-frequency non-invasive ventilation might play a role in preventing intubation. Now, when we talk about non-invasive positive pressure ventilation, non-invasive mechanical ventilation, there are very few data actually looking in non-synchronized positive pressure ventilation versus nasal CPAP. And just recently, a Brazilian group, Menezes and co-workers, did a study like that, which was a randomized controlled trial where they had 100 infants on nasal CPAP as compared to non-invasive positive pressure ventilation, with a primary outcome of the use of endotracheal tube, which is basically CPAP or N-IPPV failure. And they were not able to show a huge effect other than in infants larger than 1 kilo at birth with regard to the risk of being intubated. All other secondary outcomes like survival with no PPD, ROP, necrotizing enterocolitis, and so on were not different. Most of the studies that were comparing nasal CPAP versus non-invasive ventilation, however, were with older devices that are no longer available with synchronized N-IPPV. Now, again from Peter's group in Melbourne, Louise Owen did actually do a physiological study where she looked into the efficacy of non-synchronized, non-invasive positive pressure ventilation. And what you can see here is, again, tracings, as you've seen that before, where you have the applied pressure in the upper row. You have a signal, we're going to come to that later on, with a small capsule you probably are familiar with. That's the capsule the Infant Flow Advance is using, the Grasby capsule, that is detecting abdominal movement as an indicator of inspiration or expiration. And there are the so-called plethysmography bands around the chest and the abdomen that together give this signal ripsum that are recording also the inspiratory effort of this baby. And what you can see from the left upper panel actually is that during an apnea that is lasting over this period of time, the ventilator would provide positive pressure ventilation. However, the thorax or even the abdominal wall are not moving at all, indicating that this non-invasive, non-synchronized ventilation would not really reach the lung, and as a result, the baby would desaturate. However, some of these infants would have some more effective non-invasive ventilatory cycles. You can see some movement here, but nevertheless would have some fluctuations in saturations. And others would have eventually some large movements of the abdominal wall and the chest wall, however, not having air reaching the distal lung and desaturating. So from this physiological observation, there are some indications that non-synchronized, non-invasive ventilation actually does not really help gas exchange. More recently, O'Brien did a study where he looked into, again, the synchronized bi-level support of non-invasive ventilation. So this is Infant Flow Advance that provides two different pressure levels with two different flows, and subsequently did a meta-analysis of available data comparing non-invasive ventilation versus CPAP, and there are other meta-analyses available that actually found out that in order to prevent extubation failure, this way of non-invasive ventilatory support has some benefit as compared to only nasal CPAP. However, if you look into these trials more subtle, it turns out that most of these trials that are included in this meta-analysis are actually synchronized non-invasive positive pressure ventilation, either in an SIMV mode or in this bi-level mode. So these data kind of indicate that synchronization might play a potential role. So this is my dog, already quite old, at about 14 years, who does synchronize with this new pal he met when I was in Melbourne. So how about synchronization in general? We know from invasive mechanical ventilation that there are some potential benefits, as outlined here by a number of studies looking at tidal volume, at stress, sedation, earlier weaning, and stuff like that. But if you look into meaningful long-term outcomes, and Anne Greenough did that in the meta-analysis of all available data in intubated infants, it turns out that the effect of synchronization in intubated babies isn't that big at all. If you look into the number of patients enrolled in total, that's quite a high number. However, the relative risk for BPD at 36 weeks was not affected by synchronization in these infants. The only outcome was the days on the ventilator. So this is not a huge difference. How about synchronization and non-invasive ventilation and nasal CPAP? there is a study from the group of Bandari and co-workers in Connecticut at Yale University, where they traditionally had synchronized non-invasive ventilation over several years until the infant star with the StarSync device that was actually synchronizing this ventilation was no longer available. And they looked into their data of infants where they could only tease out a slight effect in the smallest infants with regard to BPD or death, and a little bit, sorry, of a trend with regard to neurodevelopmental impairment. However, although this number of infants enrolled in this study is reasonable, this is a retrospective data. And if you compare these two groups, actually the group with the synchronized NIPPV was quite different with regard to demographic data as compared to the non-SNIPPV group. Now, again, from an American group, Dumper and co-workers, looking into the effect of synchronized NIPPV as compared to non-synchronized NIPPV, they looked into bronchopulmonary dysplasia or death, again in retrospective way, and they didn't find a difference with regard to this primary outcome. Now, when we look into conventional ventilation versus synchronized NIPPV, there was one randomized controlled trial that was conducted in both Philadelphia and Connecticut, where they actually tried to compare the primary care of infants that were born with either conventional ventilation or synchronized NIPPV. And as you can see, these groups were rather small. And actually, this study was terminated due to poor recruitment after a while. And the primary outcomes they looked at were just at the border of significance with regard to BPD. And BPD or death, the combined outcome was significant, but if you look into death, that's predominantly due to the effect on bronchopulmonary dysplasia. So this is an underpowered study that needs further investigation. Now, if we want to use synchronized or non-synchronized non-invasive positive pressure ventilation, we need to have a device. In order to have a device, we need to know which would be a good trigger actually to be used non-invasively for ventilation. And this is something we looked into last year when I was in Melbourne, where we just were asking what are the best triggers to use in non-invasive ventilation. And when we go into spontaneous breaths, you have seen that before. This is a flow trace of an infant where inspiration is positive flow, expiration is negative flow. You can define in an intubated baby very easily the onset of inspiration as being the crossing the zero line of flow and going positively. And the onset of expiration is defined as the end of this positive flow going into negative, into the negative side of flow. And in order to determine which signal might actually be the best to be used as a trigger signal, we investigated several external signals that are outlined here. We already talked about the Gresby capsule. There are these respiratory induction plethysmography bands or RIP bands, and just recently a piezo crystal has been introduced to be used as an external trigger. I show you that later, that is moving sensitive and could potentially be used as a trigger device. Other triggers have been suggested. The flow trigger at the nasal Y piece might be a potential trigger, or more recently, one company is providing neuronally adjusted ventilatory assist, a device I'm going to discuss just in a minute. So we were asking what's the best trigger for synchronized NIPPV, and now you can see different traces of these signals in parallel. This is a spontaneously breathing infant, former preterm infant, and you can see the signal of a band around the abdominal region, and you can see the movement of this signal up and down. You can see the esophageal pressure as a deflection of pressure indicating the onset of inspiration, and you can see the signal of the Grasby capsule as compared to the known signal, the flow throughout the respiratory cycle. We looked into the onset of signal and the quality of signal, and you can see an infant covered with all these devices. There are these bands that are fixated around the abdomen and the chest. This is one of these piezo crystals. This is the Grasby capsule. And we recorded then in a number of infants. However, as you might have observed in your own infants, these external signals are compromised by moving artifacts. And this actually happens quite often. And all of a sudden, you can't do anything. Over this time, you have periods of good signal recordings, and you have periods where basically movement artifacts, apnea, or other things play an important role. So we looked into quite a number of breathing cycles, and we looked into the onset of this signal as compared to the most sensitive of all of these signals, the abdominal band of these rib bands. And as you can see, the esophageal pressure sets on only about 50 milliseconds after the contraction of the diaphragm, which results in this rib abdominal band signal, just followed by the Grasby capsule, and then later on the piezo and the rib chest. Of course, the chest is the latest because this is only indicating that the lung is filling up. And you can see the asynchrony by the angle of these two rib abdominal bands and chest. We looked also into the validity of these signals, and both abdominal band and Grasby capsule are actually the most accurate and most readily available signals for triggering non-invasive synchronized ventilation. When the baby was on CPAP, pretty much the time frames are the same, and again, Grasby capsule is doing pretty good. The esophageal pressure in CPAP is of course different because we have a positive pressure in the thorax, but basically we can say that both abdominal band and Grasby capsule are potential good signals to trigger non-invasive ventilation. Corrado Moretti in Rome has developed another device, the flow sensor at the airway opening in non-invasively ventilated infants. And he kind of developed a special ventilator called Julia for flow synchronized non-invasive ventilation with a special algorithm that accounts for the changing leak in a non-invasively ventilated infant. And as you can see, with this special device, nasal flow synchronized non-invasive positive pressure ventilation, so we need a lot more letters to explain that now. Extubation failure was actually significantly reduced in infants on this flow sensor. And the other possibility to trigger non-invasively is this neuronally adjusted ventilatory assist device, NAVA, that is available now on the market as well. What does that? This is a special feeding tube that has a built-in electrode. And this electrode is actually advanced down to the level of the diaphragm, sensing the electrical activity of the diaphragm as the onset of inspiration. And once this signal is actually detected, the ventilator would support inspiratory effort of the baby. So it looks like that. You can have the regular feeding tube used with this device, and you have the electrode attached to the electrode at the level of the diaphragm, sensing the activity of the diaphragm. Unfortunately, that's a little dark. I put a dark frame around that. However, what you can perhaps see in the front rows is the signal of the diaphragm. I outlined that right here, and the ventilator adjusting the support in accordance to the signal they are taking up at the level of the diaphragm. The nice thing about this device is that it's actually proportional to the effort of the diaphragm in order to inhale air. So this is also a way of proportionally support this infant non-invasively. Unfortunately, so far we don't have data in neonates or preterm infants whether or not this works non-invasively. However, there's a very new study just published in intensive care medicine in adults where they used this device non-invasively and were able to show that asynchronous compared with NAVA are almost completely abolished as compared to pressure support ventilation in this small study with a crossover design. So I'd like to summarize that as the possible applications from what we've seen before, which triggers might be used in the future for non-invasive triggered ventilation. Rib abdominal bands are very sensitive and available. There is the Grasby capsule that is around already for decades and has worked very nicely and is now implemented in new ventilators. The flow sensor with a special algorithm and special ventilator is available, and the neuronally adjusted ventilatory assist is also a possible application. However, so far, there are no comparative studies looking into differences of these triggers or looking into meaningful long-term outcomes. So we also don't know actually how to apply non-invasive synchronized positive pressure ventilation at all. What is the best supported frequency, and is it better to intermittently synchronize or to kind of synchronize every effort of inspiration in our patients? So there is one study that I'd like to share with you as well, is again from an American group in Miami with Eduardo Bancalari, where they again looked with the old device Infant Star and StarSync using the Grasby capsule into meaningful outcomes or short-term outcomes. And what they did is they actually compared nasal CPAP with either non-synchronized, non-invasive mechanical ventilation at 20 per minute, synchronized at 20 per minute, non-synchronized at 40 per minute, and synchronized at 40 per minute. And they couldn't find any difference in these short-term outcomes with regard to tidal volumes achieved, minute ventilation, respiratory rate, CO2 elimination, or saturations in these infants. Again, this is a small study with crossover design. However, what they found is when they looked into their tracing, they also measured esophageal pressure, and they were able to show that the work of breathing as indicated of area under the curve above the line of zero in the esophageal pressure signal was reduced in an SIMV N-IPPV mode of about 40 per minute. So more studies are needed to actually answer the question which would be the best way of providing synchronized mechanical ventilation, non-invasive mechanical ventilation. So now we were also involved in the development of new modes of synchronized mechanical ventilation. I want to just tell you a little bit about that without providing you with any additional data. So if we look into the normal ventilatory curve again, if you look into the variability of inspiratory and expiratory cycles, you can see that some inspirations are rather short, others are rather long. The same is true for the expiratory cycle. And the question is whether there is a way to non-invasively trigger expiration as we do in intubated infants during pressure support ventilation. So can we detect the effort of the baby to stop breathing, to stop inhaling and start expiring, or is that rather unfeasible during non-invasive ventilation? We know about from, again, invasive ventilation that pressure support ventilation, which is triggering expiration, might be beneficial with regard to the ventilator dependency, as shown by Rice and co-worker, who were showing that with SIMV plus pressure support ventilation, the infants get off the ventilator more easily. Now, when we look again into our tracings here, we can see that all these different signals are actually quite clear with regard to the onset of expiration. And we can just say that the peak, for example, of the Grasby signal of the inspiratory limb indicates that the baby is ready to expirate and is done with inhaling. And this is now implemented in this ventilator here, where an expiratory trigger is actually implemented at the peak of the Grasby signal during regular ventilation of the baby, and thus resulting in different inspiratory times the ventilator is providing during non-invasive ventilation. Whether this is good or not, I don't know, and we have to study. Another problem during non-invasive ventilation are apnea. So instead of having a ventilator that is coping apnea in the intubated infant, where you just keep on going and pressing air into the lungs, during non-invasive ventilation, we can't easily do that because quite often there's a closure of the glottis, or the baby is just fighting the ventilator, or wouldn't just let enough air into the lungs to maintain FRC. So again, we were discussing back and forth with the manufacturer what to do about that. And now with a signal from the surface of the baby, like the Grasby capsule here, you can detect whether or not the baby stops ventilating, and then you can dial in the duration of apnea you might accept until the ventilator pops up and then supports the baby with a higher frequency as it would during regular spontaneous ventilation. However, the movement problem I've shown you before is not yet solved, of course, because if the baby starts moving a lot, all of these signals kind of go out of range, and there might be further efforts to cope with that, and we have to see what future developments will show us. Now, I'd like to summarize here and state what's available with regard to data, and this is very weak, as you've seen. Synchronized intermittent mandatory non-invasive ventilation at 40 per minute seems more effective than only 20 per minute non-synchronized. However, we don't know about assist control non-invasive ventilation. Triggering expiration is now available, and we have to evaluate that. And apnea detection is available, but we don't know about the significance of that. And moving artifacts are still the major backdrop of non-invasive synchronized positive pressure ventilation. So you can see there is a lot to do. It's work in progress. And I'm sorry for any inconvenience. And I'd like to thank the NICU team in Melbourne for the support last year, Peter Davis, of course, Andreas Schulze from my unit, and all the other people who helped with that. Thank you very much. Should we have discussion now here, Peter, all together, or I think we have time enough. Janusz, what do you think?
I propose to discussion and then the next lecture, and then we will move to for coffee and social meeting.
Okay, so we skip the coffee break and have the next. Okay, so who has questions? What's that? Right. So questions on non-invasive ventilation. Who is actually using non-invasive ventilation over CPAP here? We do. Yeah. Are you using synchronization in some way? The bi-level synchronization, the infant flow advance, who is using that? A few. Are you aware of the infant star, the old ventilator? We still have one in the closet. Eventually use it. Nobody's using it. Okay, good. Any questions? Also for Peter?
Some people believe that increasing frequency of non-invasive ventilation increases the elimination of CO2. In the study you showed us, that was not true. Is that an evidence that it works or not?
Well, this is a very small crossover study. I wouldn't draw too much conclusions from that. I don't know. We have to look into that. The old studies actually with the infant star, to my knowledge, were predominantly used in the assist control mode. But that's not really outlined in all studies. Peter knows that better because he wrote the media analysis. So as far as I know, most of them are in assist control mode. Yeah.
But in your own practice, if you had an elevated CO2 level in a baby who is on a non-invasive ventilation, do you increase the rate in waiting for the PCO2 to lower in that way?
Well, it depends on the level of CO2. We also look into pH, and if the pH is not below 7.2, 7.25 sometimes, we wouldn't do too much if the baby is comfortable. When we use non-invasive ventilation, we now, without actually having a lot of studies available, are using synchronized NIPPV more in the assist control mode. So every single breath is supported. So it doesn't make a lot of sense to increase the rate there.
Of course, thank you.
Mm-hmm. Anton. Yeah.
I think it's important to realize that the question you're asking is that if the things you do with invasive ventilation also apply during non-invasive ventilation. And I'm not so sure because actually we don't really know how non-invasive ventilation works. The studies shown by Andreas, they don't have a real effect on tidal volume or on minute volume. Might well be that it's the clearing of the CO2 from the upper airways or just the stimulation of a puff in the upper airways that keeps the baby going on with breathing. So going up from 30 to 40 or 50 per minute in frequency might not be a thing that actually impacts clearing CO2 or stimulating the baby to breathe. So before we can answer these questions, we have to figure out how it really works.
Yeah, but there's no proof. We don't know. And actually, in the non-synchronized NIPPV, it might be merely an elevation of the overall mean airway pressure that you achieve with these extra puffs. We don't know that. Other questions? So you if you don't have any further questions, we just proceed. Is that okay? That's the plan? We go into humidification, shift gears. Yeah? Huh?
So there's one thing I would like to comment on, if you allow me, Andreas. For me, it's very important that to distinguish between primary non-invasive ventilation and secondary non-invasive ventilation. And the meta-analysis shows that if you use non-invasive ventilation, that you might prevent reintubation with your patients. However, it's not the same for me that every baby that you extubate should primarily be put on non-invasive ventilation. For me in the unit, we start on CPAP, and you know that if the baby is not responding to CPAP, then in a second time you can switch to non-invasive, and you probably will get some babies off the ventilator. So I think it's an important distinction.
Absolutely. And actually there are very few data supporting synchronized non-invasive ventilation as primary care in the delivery room. Very few data. Now let's go to the rainforest. It's not a cold rainforest in Australia. It's somewhere else. And now the final talk for tonight is airway humidification. That's usually something you don't care about because the nurses care about that, right? Who is actually looking into conditioning of gas in your unit? Do you? Who takes care about the humidification box or chamber? The nurses, right? The same in our unit, actually. And thanks to Andreas Schulze from our unit, who is my boss now for almost 10 years, I got really interested in that issue because if you look into the details, it's actually something you should look into in your unit, and you should be aware of the pitfalls of airway conditioning. And like Jerome did this morning, I'd like you to take away a few messages, and this is one of that. If you don't listen now and fall asleep, just go on the internet and get this paper. It's pretty good. Now, I like to share with you some physiological issues, definitions, and then go into technical and clinical aspects of gas conditioning during mechanical ventilation and also during non-invasive ventilation. If you look into the anatomy of our airways, then actually we have a pretty well-designed equipment to condition air while we breathe in. Because the aim of this equipment is actually to provide air at 100% relative humidity with 37 degrees down at the bifurcation of the trachea. And this is, in general, achieved. Now, how is that achieved? This is achieved by the tracheal epithelium. And this is an immunofluorescence slide of the tracheal epithelium of a rat, where we actually marked the so-called sodium-potassium 2-chloride channel, the sodium-potassium 2-chloride 1 channel, that is one of the equipment of the epithelium to secrete large amounts of fluid and mucus into the tracheal lumen and actually onto the surface of this epithelium. Now, if you look into the details of the tracheal and respiratory epithelium, you know from your early medical training that there are different types of cells that actually bear a fluid film on top of them that is moved towards the mouth opening with some jelly areas, that's the mucus, that is trapping both bacteria and solid particles of the air we are inhaling towards our mouth, and we get rid of that. So that's a very efficient way of humidifying the air and cleaning the airways. And actually this film is supported by the cilia-bearing cells of the respiratory epithelium, and these cilia are moving very rapidly, moving this film towards the mouth opening. And this is essential for our breathing pattern at all. And as you know, if the movement of the cilia is impaired, you end up with Cartagena syndrome as a disease that is comparable to cystic fibrosis. Now, what is humidity? And we heard about humidity in the incubator already, and I was saying to Jerome that if you see a lot of rain out at the walls of your incubator, something is wrong with the environmental temperature, and your humidity in the incubator is never what you want to achieve, because you're losing humidity once you see rain out. Now, in order to understand that, we go a little bit through the physics of humidity. We know absolute humidity is actually the content of water in milligrams per volume of gas in liters. And you don't really deal with absolute humidity at all. However, it's very valuable to know about that, because it helps you to estimate whether or not your heating humidifier is actually working well. And we come to that later. Now, in a given gas volume, the amount of water that can be bared by this amount of gas, say 1 liter of gas, is completely dependent on the temperature of this gas. Now, at the level of the bifurcation of our airways, the gas usually reaches 37 degrees Celsius, and that can be saturated with water to 100% if 44 milligrams of water are in this amount of gas in 1 liter. So this is now a physical constant you keep in mind throughout this talk. 44 milligrams of water per liter of gas is an absolute number of humidity you can reach, and that results in 100% of relative humidity. We only adjust the relative humidity in our heated humidifiers, in our incubators, but actually we need to know how much water is in there in order to really determine whether we reach what we want to reach. Because if the relative humidity is decreased, the amount of water in this volume of gas is reduced. The relative humidity is calculated as the actual water content in this volume divided by the maximum content of water we could achieve if we would have 100%. Is that concept clear, or did anybody not understand that? It's not so difficult, right? Good. Let's continue. Now, when we have a heated humidifier, what we usually use, we would like to achieve 100% relative humidity at 37 degrees Celsius, equaling 44 milligrams per liter of gas. So that's normal. Now, we have to keep in mind that once air that is conditioned to 100% cools down, it loses automatically some amount of water. For example, if we cool air down to 30%, to 30 degrees Celsius, then the maximum humidity you can achieve at that temperature is only 30 milligrams per liter. Once you reheat this gas, you're not going to achieve 100% at all if you don't add additional humidity. You end up with a relative humidity then of only 65%. So if you go back to your incubator, once again, you have to keep in mind, if you see rain out at the walls of this incubator, you're not going to have the humidity you want to achieve, and your digital numbers show you it's no longer 80% or 60% or 70%. You're losing substantial amount of humidity if you have rain out. And you only can increase the humidity again if you add water. Okay? And the same is true for the conditioned gas in our tubing system until it reaches the child. Now again, if you reheat, you're going to be down at 65%. Now, back to physiology. If we look into our airways, usually what we inhale is air at the best of a relative humidity of 50%. But this is very rare. Usually we have much lower relative humidities. That equals an absolute humidity of about 9.7 milligrams per liter at a room of 22 degrees. If you're down in Brazil, it's probably different. And then once the air enters the nasal cavity, the relative humidity very rapidly goes up to 95%. You see how effective this equipment we have is. And it's already heated up to 30 degrees. However, the absolute humidity here is only 28 and far from what we want to reach. Once we go down the tracheal lumen, we'll increase the relative humidity very rapidly to 100%, increase the temperature, and down at the bifurcation, we reach relative humidity of 100%, equaling this 44 milligrams per liter at 37 degrees Celsius. So this is what we want to achieve once we have our baby intubated. Now, what are the goals of sufficient conditioning of gas during invasive ventilation? We want to be as good as nature is. So we want to have sufficient heating and humidification of the inspired air in order to protect airway epithelium and avoid excessive thawing and condensation during mechanical ventilation. What are the possibilities? Well, a very easy approach would be to just instill fluid into the endotracheal tube, and that actually has been used previously and is a very rude method of humidification as well. Another possibility, and that's not so bad at all, is passively using so-called humid noses, which can actually exchange water and exchange temperature. But the most efficient one is the nebulization to maintain and to reconstitute physiological conditionings. Now, how about fluid installation? It's very difficult. You don't know the adequate amount. You can hyperhydrate or hypohydrate. And most importantly, you can have airway obstruction due to swelling secretions if you instill distilled water. And there's a problem with hyperosmolarity with normal saline. So that's not a good approach. As compared to the passive humidification. Who is using passive humidification, let's say, at certain circumstances, for example, in the operation room? We might use that as well if we don't use heated humidifiers. And actually, these heat-moisture exchangers, like here, on a baby with a tracheal cannula, or the hygroscopic condenser humidifiers with this endotracheal Y-piece adapter with this piece of paper in here are quite efficient in providing at least some humidification. They can heat the inspired air to a maximum of 32 degrees, even if the ambient temperature of the gas you apply is only around 20 degrees. And these sponges or papers are covered with hydrophilic substances, for example, calcium or lithium chloride, and they have some activity against bacteria and viruses because of bacteriostatic coating. And these devices have been compared to heated humidifiers, and it has been shown that over the time of 50 minutes, they are able to provide at least an absolute humidity. Now you know what would be normal, 44 would be normal, of about 32 milligrams of water per liter. But if you look at these data more closely, you can also see that the heated humidifiers are not as good as the vendors would tell us. They are only providing about 37 milligrams of water per liter of gas. So there is actually some possibility to improve that. Now, heated humidifiers as compared to the passive humidification devices that are very easy to handle. They are quite cheap. It's a passive technique, but rather no condensation is actually occurring in the tubing. However, as I've shown, the absolute humidity we can achieve with these devices is not more than 32 to 33 milligrams per liter. The heated humidifiers are safe and effective, but they are quite complex systems, although the modern systems are rather internally regulated. They are expensive, and the question is whether or not there is a risk of contamination. What would you say? Is there a risk of contamination or not? Well, the reason or the risk of contamination very much depends on the way you're using these devices. Because in general, heated humidifiers are aiming to vaporize water. So what they produce is actually molecular water. So vaporized water is not able to transport any bacteria because bacteria can't live in molecular water. However, if you have rain out and nebulized water, these particles might be as big as up to 5 micrometers, and this is actually a pretty good area where bacteria may live. So you have to be sure that your device is working properly. Now, Davies, not Peter Davis, have been looking into the efficacy of humidified heated humidifiers, and they have measured temperatures and humidification down the ventilator tubing system into the endotracheal tube down to the tip of the ventilator. And actually what they found is that when you use a heated humidifier with a heating wire in the inspiratory limb close to the Y-piece, after this heating wire, the temperature should be set up to 40 degrees Celsius because only by this adjustment, and now you have a relative humidity of 85, you are able to actually reach 37 degrees, 100% relative humidity in the endotracheal tube in the patient. This group now just recently looked into the real efficacy at different temperature settings of heated humidifiers, and it turns out that once this endotracheal tube reaches the baby, actually the absolute the relative humidity in reality is far from 100% as compared to what we want to achieve. So gas conditioning is an important issue because poor gas conditioning might result in airway damaging, and the different heating devices are working differently. And you have either heating devices with gas bubbles through a heated bath, like in the Weber or Stefan heater, or you have gas that sweeps over heated water, like in the Fisher and Paykel or the SAB 322, or there's another one like the Aqua mode, where gas sweeps along water-filled semi-permeable capillaries, which is, I think, no longer available. And direct water vaporizers like the VH620. Now, in the endotracheal tube intubated infant, we are actually bypassing this very efficient nasal cavity, and we have to be sure that while the endotracheal tube enters the trachea, we still maintain this normal conditioning. And how would you actually know whether or not your humidifying heater is working appropriately? And this is, from my point of view, actually the most important slide of the whole talk. And you take that home because you can actually control your heating humidifier by looking into the water consumption this device is using over time. And that's a very easy calculation if you assume that your ventilator has a sweep gas flow of about 6 liters per minute, which is more or less what you use in your ventilators. Some ventilators you can set the flow and then you can recalculate. Others are in the demand flow mode and you don't really know how much gas they are using, but it's around that number or even a little bit of higher, like 8 or 10 liters, and then you have to recalculate. But you know, if you have 100% relative humidity at 37 degrees, you want to use up to 44 milligrams of water per liter inspired gas. Now, a lot of this water actually gets lost in the expiratory limb, of course, but the amount of water your heating humidifying chamber is using, you can calculate that with these given numbers, that should sum up to about 380 milliliters of water per day on the ventilator. So now if you're not sure whether your humidification is working properly, why not you just go ahead and ask your nurse to write down for a certain amount of time how much water this humidifier is actually using, and then you can calculate whether this is within, of course this is plus minus a little bit, whether this is within the expected value. And if it's not, then your baby is at risk of having problems with regard to thickened secretions or even epithelial necrosis of the trachea. Now, these are the major risks of inadequate humidification. You impair the activity of the ciliary of the bronchial epithelium. You have retention of secretions up to the occlusion of small airways or even your endotracheal tube. You have impaired mucociliary clearance of microorganisms, so your patients are more prone to develop nosocomial infections, and you have the increased risk of inflammatory necrotic changes of the airway epithelium. And there is also, with an inadequate humidification and conditioning of the gas, the risk of energy loss and heat loss of your baby. So if you don't provide enough humidification, you might need more fluid to administer to your baby because you're losing water and you're losing heat. The risk of gas conditioning might be overheating of the inspired air. It might be fluid overload if you're doing it too well. Let's say if you're heating your chamber up to 40 degrees, 100% humidity, then you might have rain out in the endotracheal tube or the trachea, because then at 37 degrees you have rain out that might lead to aspiration of condensed water or and subsequent occlusion of small airways, and again promoting intrapulmonary infections. So the question is, how about the danger of increasing the temperature of your ventilatory tubing? Because the setting in a Fisher and Paykel heating humidification chamber actually is that the chamber itself heats the water to 37 degrees in order to achieve 100% relative humidity. And subsequently, the inspiratory limb of the tubing is heated up to 40 degrees. Is that a problem if a higher temperature reaches the trachea? Actually, you can calculate that, because 37 degree, 100% relative humidity bears an energy of 143 joules per kilogram, per gram. Now, if you increase the temperature of this air without adding humidity. The relative humidity, as I've shown you before, drops to actually 90%. And the energy you put in there increases very little. So actually the risk of heat trauma is quite little, especially because on the way down the endotracheal tube, the gas will be cooled down to 37 degrees again, and that has been measured before. So the major risk of inappropriate gas conditioning during invasive ventilation and also during non-invasive ventilation is rainout. How does rainout occur? This now is a ventilator tubing that has heating wires on the outside of this tubing. However, as you can see, here's the inspiratory limb, here's the expiratory limb, that in the inspiratory limb you have a very small droplet rainout, indicating that the environmental temperature might be quite too low, or the settings of your tubing heating is too low, and result in rainout and loss of humidity in your ventilator tubings. And the same is true at the Y-piece. This is a closed suctioning device. You might notice a lot of rainout here. If you have a problem like this, you don't want to reduce humidification. You want to increase the temperature of your tubing in order to provide rainout during cooling. For example, if you have the temperature of your incubator at around 32 degrees, you should use the open cart ventilator tubings in order to have tubing heating up to the Y-piece. Okay? And that prevents additional rainout. So pitfalls of the vapor heater are, for example, defects or lacking thermistors. Now, if you have a thermistor that is placed into the ventilator tubing and is covered by rainout, by droplets, this tubing thermistor will read wrong temperatures because by evaporation of fluid from the thermistor, it will read too high temperatures. And as a result, the machine would downregulate the heating of the tubing, and you will have increased rainout. So as a result, what you should be aware of is keep the thermistors on top of the tubing, and if they are wet, dry them out in order to have right readings. And again, you can control that by just measuring the water consumed by the humidification device. Look at the development of condensed water and be aware of what I just said with the thermistor that is wet. Now, you can control clinically whether or not humidification and gas conditioning is adequate if there's enough water consumed and you don't have condensation and the gas temperature at the airway opening reaches around 37 degrees. It might even reach higher temperatures because then again you don't add water, you just add temperature, and you're not prone to traumatize the trachea or the respiratory epithelium by too much heat. If you don't condition right, then you might have problems like this baby. It is previously very low birth weight infants after 3 months and 3 days after laser coagulation therapy due to ROP. Now, what happened here is this baby had a very long procedure of laser therapy due to ROP, which took 3 hours. And during these 3 hours, the infant was ventilated in non-conditioned manner by the anesthesiologist because they basically did not have airway humidification. And this baby came back with a severe necrotizing bronchopneumonitis that lasted over several days with recurrent atelectasis and very, very viscous secretions, and was quite sick. This is a result of inadequate gas conditioning in these very prone infants. There's another case I'd like to share with you of an extremely low birth weight infant with a birth weight of 540 grams. It had ureaplasma infection and had recurrent airway obstruction due to very viscous secretions. And this child actually developed repetitively airway obstructions, and at 30 days of life had a obstruction of the endotracheal tube that basically led to overinflation of the lungs and to atelectasis of the left upper lung and the right upper lung, due again to increasingly viscous secretions. The baby eventually had occlusion of the right main bronchus the other day and was extubated, and you can see the occlusion of the endotracheal tube with a very thickened secretion here. And after later workup, it turned out that the heating humidifier was not working properly, not using enough water because one of the thermistors was defective. So if you have a baby like that with recurrent atelectasis, with recurrent tube obstruction, or main bronchial, distal bronchial obstruction, take into consideration that inadequate humidification might be a reason for that. So this is a good way of humidifying our babies, and I'll be open for questions. Thank you very much. You're all flattened. You want to have the beer soon and coffee, right? Yes.
Just a very practical question on having patients on transport, where I'm afraid I don't know, but I would suppose that the air coming from the pressurized container will lose heat, so it will be significantly below 22 degrees. Do you think what we should be even more caring about the air than just popping in the humid nose?
That's a very good question, actually. And going on transport myself, we were discussing that back and forth because we actually got very sick babies on dry air transferred. And as a result, we now finally decided to have a transport system with a heated humidifier. And we use that now on transport of critically ill infants. And for the non-ventilated or non-invasively ventilated infants, perhaps that's not so crucial, but with a sick baby, I would suggest to have heated humidification. If you have it available. There are cheap humidifiers for transport as well. Yeah. Other questions? So if not, thank you very much. And we'll see each other at coffee and beer, I think.
Yes, sorry. We would like to invite all of you for, as you said, coffee and a beer, which will be in a restaurant now, and it will be a social meeting for all of you. So we would like you to enjoy it. Thank you.